Start now. Good evening, one and all. I welcome you to the webinar on update on our keratoconus. This actually we are conducting CMEs as a part of our Golden Jubilee year in Aravind Eye Care System. This this webinar will be one among this, and today we'll be talking about update on keratoconus. And first, Dr. Christy from Pondicherry, she is leading the department in Cornea and Refractive Services. She will be talking about workup and monitoring progression in keratoconus. Over to you, Christy.
Yes, ma'am.
As she is loading, you can introduce the panelists, Dr. Mangala.
And we have two esteemed panelists, Dr. Revati Madam, and Madam is the Senior Consultant and Chief of Cornea and Refractive Services, Aravind Eye Hospital, Coimbatore, and Dr. Nartika Natarajan Madam, Director of Shankar Nethralaya, two esteemed panelists, and they will be guiding us and showing light on how to go ahead with the treatment on keratoconus. Welcome, ma'am.
Okay.
Yes, Dr. Christy, you can start.
Yes. Thank you so much, Mangala ma'am, for the opportunity to join in this virtual webinar. And it is such an interesting topic to cover. And my greetings and respects to our teachers here, Dr. Revati ma'am, Dr. Radhika Natarajan ma'am, and Dr. DC sir. Thank you for joining us today. So I'll be talking on keratoconus workup and how to monitor progression. So the definition of keratoconus, so this is a bilateral, asymmetrical, and progressive corneal thinning disorder with ectasia, and it leads to irregular astigmatism and decreased visual acuity. So it is a clinically non-inflammatory condition, though there are plenty of studies to prove there is an inflammatory background for this. And the clinical features, it starts in the second decade and progresses until the fourth decade. And there is no typical gender predilection for this, though it is commonly seen in males. And the symptoms are most often blurred vision and frequent change of glasses and image distortion. So moving on to the clinical workup, the retinoscopy signs is one of the earliest that we see, that is the scissoring reflex, where we see two bands of light that is reflected from the retina and moving like the pair of scissors. And the oil droplet reflex, it is visualized in the distant direct ophthalmoscopy. And the other Strickland signs are seen in moderate keratoconus, where there are iron deposits at the basal epithelials, which is called as the Fleischer's ring, typically seen better in cobalt blue or green filter. And the other signs are the Vogt striae. These are the fine vertical stress lines in the deep stroma that are parallel to the steep axis of the cone. And these lines disappear transiently on gentle digital pressure. And corneal thinning is another commonly seen clinical sign, though it is more evident in the cases of moderate and severe keratoconus. And the other signs, which is the name signs seen in advanced stages, are the Munson signs, which is the V-shaped conformation of the lower lid, and the Rossetti sign, which is a sharply focused conical beam of light in the nasal limbus. And corneal apical scarring is another sign that is seen in advanced keratoconus. And hydrops is a condition where there is a stromal edema because of aqueous humor imbibition into the corneal stroma caused by acute rupture in Descemet's membrane, and this leaves behind a posterior stromal scarring. And the other non-specific sign is a prominent corneal nerve, and very rarely we also see Bowman's layer ruptures. And there are various nomenclatures used in keratoconus. The subclinical keratoconus is where there are no clinical signs at all. Patient also sees 6x6 with spectacles, but they have a suspicious or a topographic keratoconus. And the clinical keratoconus, there are three stages: the early or the mild, the moderate, and the advanced. In the mild keratoconus or the early ones, we just see the retinoscopy reflex, whereas in the moderate ones, that is when we see the clinical signs, but the patient is not able to read 6x6 with glasses. Whereas in the advanced keratoconus, the patient is not able to read 6x6 even with contact lens wear. And the formi frustae is the normal eye of a keratoconic patient, that is the other eye has keratoconus. And keratoconus suspect has a contralateral normal eye, but topographical suspicious changes. And so this can be a very normal cornea, but they can have a subclinical keratoconus. So this is an early or mild case. This is a moderate keratoconus. This is a severe keratoconus with apical scarring. And this is a case of acute hydrops. So moving on to topography basics. Basically, there are two terminologies used here. The corneal topography is a non-invasive two-dimensional imaging technique. This maps only the anterior corneal surface. Whereas the corneal tomography, so this is computing the entire 3D image of the cornea, giving us more details of the entire cornea, both anterior and posterior surfaces. So, and some basics are the steep areas and the high curvature areas with high keratometric power are marked with warm colors. The normal ones are green and yellow, and the cool colors that such as the violets and the blue are given to flat areas or areas with low keratometric power. So in OBSCAN, a summary map, typically you have 4 images like this of anterior elevation, posterior elevation, axial curvature, and corneal thickness. The same can be seen in pentacam maps as well. So in a normal curvature map, we see a symmetrical bow tie pattern, which is vertically oriented in a with the rule astigmatism and horizontally oriented in against rule astigmatism. So in keratoconus especially, the 5 mm zone is very important, and we look into the IS asymmetry, that is the inferior versus the superior difference. And if this difference is more than 1.4, it is significant for keratoconus. And what is skewed radial axis? Here you can see the inferior segment A, and the superior segment B is not exactly opposite to the A segment, and it is skewed to the right. And the angle degree corresponding to it is 30 degree. So it is skewed from the 70 degrees. So this difference is 40 degree. So when the SRAX is more than 21 degree, it is indicative of keratoconus. So now elevation maps. So here elevation maps, if you see, this is different from the curvature map. The horizontal elevation, if you see posteriorly, that is, it is above the best fit reference body. So it is given in positive, that is in red color, whereas the vertical one is in blue color. So the normal elevation map is a symmetric hourglass pattern. The negatives are seen are depressions and the positives are elevations, and the clinically important zone is the 5 mm zone. So in keratoconus, we see tongue-like extensions and isolated islands. So you can see the warm red color spots there. And also we have values for anterior and posterior elevation values, like more than 12 for anterior and more than 15 for posterior elevation in BFTE is significant for keratoconus. So looking into the pachymetry map, here again, the 5 mm zone is important. The difference between the superior and inferior pachymetry is usually within 30 microns. In keratoconus, we see the thin area here indicated by the yellow color area, oval area, and also it is displaced inferiorly and temporally, most commonly. And so this is the pachymetric thickness profile. So here we see the how the thickness of the cornea decreases from the center to the periphery. So normally after the 6 mm zone, it drops. The patient's profile is given in red color, and it always stays parallel to the normative black lines. So in keratoconus, you can see quick slopes or S-shaped curves. That is even before the 6 mm. You can see in this image after the 2 mm radii itself, there is a significant thinning of the cornea. So this is significant for keratoconus. So to summarize, if you see, you can see in the keratoconus, and this is the corneal front map. So the values that we see here are the first thing to see is whether the quality of the scan is okay, and then you look into the K1 values, the K2 values, the K mean values, the astigmatism. If it is more than 1.5 diopters, it is suspicious for keratoconus. And then we look into the cornea back, and the other values like the thinnest local. So the thinnest local, if it is less than 500, you think of keratoconus, and also how it is displaced. So the Y value of this thinnest local is one thing that we look into. The minus indicates an inferior displacement, and if it is more than 1, it is indicative of keratoconus. And the K max, if it is more than 47.2, that again fits into the Rabinowitz criteria. So as you can see here, to summarize, you can see the high keratometric power here, the steep cornea, and correspondingly we have the front elevation again marked in red zones with the elevation numbers like plus 32 and plus 30. Correspondingly, we have the posterior elevation, which is more red and warmer, and also the thickness also is yellow to red here, indicating that this is a typical keratoconus patient. So the Rabinowitz-McDonald criteria is the central corneal power K of more than 47.2 diopters, IS asymmetry of more than 1.4, SMK astigmatism of 1.5, and skewing of radial axis of more than 21 degree is indicative of keratoconus. And this is another beautiful Bellin-Ambrosio ectasia display which the pentacam offers. So normally the keratoconus cone, when it is fit along with the best fit sphere, it is not well seen. Whereas when it is fit with a new reference shape, we see these cones very enhanced. So that is the advantage of the bad display. So in early keratoconus, in the subclinical stages, we can see marked changes here. The posterior elevation is typically more than 14 microns. The progression, the corneal thickness spatial profile can be seen here, and also the total bad D. So there are 5 deviation values that are given here. DF, that is the deviation of the front, back elevation, front elevation, back elevation, the pachymetric progression, the thinnest pachymetry, and the Ambrosio relational thickness deviation. So all of these things put together is the total D or the final D, and if it is more than 2.6, it is indicative of keratoconus. Now, moving ahead to why monitoring is important to keratoconus. So this helps us to decide the timing of collagen cross-linking. It helps us to detect the subtle changes even before symptomatic vision loss, to monitor the post-CXL stability, and to guide contact lens fitting. So if we look into progression criteria, a corneal topography will give us SIMK and astigmatism. So in the SIMK, if it is more than 1 diopter increase, that is the most commonly used one. And the astigmatism, if the degree of astigmatism shifts by more than 10 degree, or if the astigmatism dioptric value increases by more than 1. So these are signs of cone migration. But very, very classic progression criteria is the Kmax in pentacam tomography, which the increase of more than 1 diopter, the thinnest pachymetry thinning of more than 10 to 20 microns, and the posterior elevation. So the posterior elevation and the thinnest pachymetry, these are more sensitive tomographic progression markers. These changes well ahead of the Kmax changes. So, and also the pentacam gives us beautiful display of 2 topometric exams. You can see the astigmatism, the thinnest local, the Kmax. So the Kmax is increased from 49.6 to 51.2, clearly indicating a progression, which was just 10 months in difference. And the bad D, that is the Berlin-Ambrosio ectasia display. So these indexes are very, very useful in the early stages, in the subclinical stages, even if the topography maps are normal. So these changes strongly correlate with the early biomechanical changes. And very interestingly, the posterior elevation and the pachymetric progressions are the first ones to change. And so these are 2 scans from 2022 and 2023, where you can see the DB and the DPs are more different when compared to all the other deviation values. And it also gives us a Berlin ABCD progression display. So this is a very standard way of detecting and documenting progression of keratoconus. And if it is more than this 95% confident interval, it goes beyond this red bars. And then aesosity in keratoconus. So this is one of the very structurally to find layer specific changes in keratoconus. This is used, and very specifically used for early and subclinical keratoconus in patients who have stable topography, but you want to see whether there are any changes. So these can be used. The epithelial thinning is one of the very early structural changes that happens even before tomographical changes or topographical changes, typically marked by epithelial thinning in the area of cone. One thing to highlight here is if you see topography images, the thinned areas are marked in red or warm colors, whereas in the aesosity, the epithelial thinning is marked by blue colors, and the pachymetric areas of thinning is also marked by blue colors. So in aesosity, the classic progression criteria is the focal thinning of the epithelial thickness map of more than 1 to 10 microns or new donut patterns. And also around this area of thinning, you can see paracone epithelial thickening. And the recent ones are the corneal biomechanical testing. So these are the corneal biomechanics is basically a measure to test the corneal hysteresis. So corneal hysteresis is nothing but the measure of viscoelastic dampening of the cornea. So which reflects the ability of the cornea to absorb and dissipate energy when force like an air puff is applied to the cornea. So ocular response analyzer, this is most commonly used in glaucoma, not very specific for monitoring progression for keratoconus, whereas Corvus ST, this uses a high-speed stream flow camera to record corneal deformation response to an air puff. So this is more sensitive to early ectasia and progression, and it gives us a very quantitative data on the deformative patterns, and it gives us a real-time data. So moving on to the risk factors for progression. So all of us should be aware that whenever the disease manifests in the early age, there is a high risk for rapid progression. Presence of diseases such as Down syndrome, allergic conjunctivitis, there is a high risk that these corneas can progress quicker. higher the corneal curvature, higher corneal cylinders, and presence of keratoconus in one eye should, all these things should highlight that the progression can be significantly quicker in these patients. And the monitoring schedule, approximately these can be followed for high-risk patients every 3 months, for moderate risk to suspicious patients every 6 months, and for low risk or stable adults, annual follow-ups, and for post-cross-linking, every 1, 3, 6, and annual follow-ups are required. So the role of a clinician, to summarize, is whenever you suspect a keratoconus. So when do you suspect a keratoconus? When the astigmatism is more than 1.5 diopters, when the best corrected visual acuity is not improving to 6/6, and there is frequent change of spectacle power, there is an asymmetric refraction, positive family history of keratoconus, and there is a history of chronic eye allergy, VKC, or eye rubbing association. So these all should push us to think for keratoconus and screen for keratoconus, look for clinical signs, and ask for keratometry readings, look for scissor reflex, and refer for a corneal topography. So I think I was able to cover a very gross summary of workup and monitoring, and thank you all for your patient listening. Thank you.
Thank you, Dr. Christie, for effectively capturing all the key points while also bringing together the most important aspects on the workup and monitoring of keratoconus. I know it's a very difficult topic to cover within 10 minutes. It does take a lot of practice to actually look at maps and learn what exactly happens. I think that is more important, especially from the postgraduate point of view, to look at the maps and learn. I think for want of time, we will first finish all the talks and then have discussions on this. So the next topic will be covered by Dr. Devi Rosset. She works at Arvind Eye Hospital, Coimbatore. She takes care of the contact lens departments. She'll be talking to us on corneal cross-linking and non-surgical management of keratoconus.
Good evening, everybody. Going to the topic, management of keratoconus. Is it visible? Are my slides visible?
Yes, madam. Just for the audience, if you have any questions, please post it in the chat box. Sorry, madam, you can continue.
The main objectives of keratoconus management include to halt the progression of ectasia, control of allergy, and visual rehabilitation. Coming to the first topic, corneal collagen cross-linking. I'm covering the history, principal indications, contraindications, surgical technique, effects and safety, complications, advances of CXL. Coming to history, the concept of CXL was introduced by the researchers at the University of Dresden in the late 1990s. They used UV light to induce collagen cross-linking via the oxidation pathway in riboflavin-soaked porcine and rabbit corneas. Post treatment with riboflavin and UV light, the corneas became stiffer and more resistant to enzymatic digestion. Human studies began in the year 2003, and the results showed flattening in 70% of patients and improvement in visual acuity in 65% of patients. So coming to the principles, photosensitizer in the presence of UV light incites photochemical reaction. In CXL, riboflavin is the photosensitizer which gets excited by the UVA light. The UVA light has a wavelength of 370 nanometers, and the irradiance needed is 3 milliwatts per centimeter squared, and the total fluence achieved is 5.4 joules per centimeter squared. UVA exposure on the riboflavin generates reactive oxygen species, which results in covalent bonds between the collagen molecules and proteoglycans. So this schematic diagram shows How first the riboflavin drops are instilled, followed by once the corneal stroma gets saturated with the riboflavin, then UVA light is exposed. So in the presence of UVA light, the riboflavin gets excited, and in the presence of oxygen, photochemical mechanism takes place. There are two types of photochemical mechanisms in CXL, both aerobic and anaerobic. The final result is formation of covalent crosslinks between the corneal stromal collagen and the proteoglycans. So, as already discussed, Christy had pointed out the progression of ectasia features. The time period is most commonly followed is 1 year, and the increase in K values of by 1 diopter, or a decrease in corneal thickness of 10%, or an increase in astigmatism or myopia of 1 diopter is usually taken as progression. So what are the indications of corneal collagen cross-linking? It is the most common indication is keratoconus. However, it is also indicated in PMD, post-LASIK ectasia, infective keratitis, and bullous keratopathy. The contraindications are whenever the cornea is Crohn's, prior herpetic infection, concurrent infection, severe corneal scarring, history of poor epithelial wound healing, severe ocular surface disease, and autoimmune disorders, as well as pregnancy. So what is the basic surgical technique followed? Initially, it was the Dresden protocol. Anesthesia is, GA is indicated in children and uncooperative adults. Topical anesthesia is the routinely followed anesthesia in adults. Initially, epithelium is debrided. It is either manually debrided or alcohol can be used. You instill 0.1% riboflavin drops every 5 minutes for the initial 30 minutes, followed by UVA exposure for the next 30 minutes, along with concurrent application of riboflavin drops. After the procedure, antibiotic drops and BCL are applied. And the post-op regimen includes topical antibiotics for the first week, and then for with topical steroids in tapering doses for the first month, along with topical lubricants. Once the epithelium heals, BCL is removed. So this is the video of a patient undergoing corneal cross-linking. Wash the ocular surface, then dry the surface. Then the central 8 mm is marked with a trephine. And the epithelium is debrided. And a foam sponge is placed, ring-shaped foam sponge is placed over the limbus to protect the stem cells. After which, instillation of riboflavin drops is started. After 30 minutes of riboflavin application, UVA light exposure is started. During a UVA exposure, riboflavin instillation is continued. Continued for 10 minutes. After the UVA exposure, the ocular surface is washed and then a BCL is placed. So there are many variations in surgical technique being followed now. In riboflavin delivery, you can use with can be done with epithelium on as well as off. Off is the basic Dresden protocol. It has the advantages of better riboflavin and UV absorption, deeper and more effective therapy, more corneal stiffening, flattening, along with lower risk of post-CXL ectasia progression. Whereas epithelial on techniques have its own advantages of faster return to baseline vision, shorter duration of discomfort, lower risk of infection and haze. And in cases of thin corneas with pachy of less than 400 microns, you use hypoosmolar CXL, which helps in further swelling of the corneal stroma and thereby protecting the endothelium. And the recently most commonly followed technique is the accelerated CXL, which follows the principle of Bunsen-Roscoe law of reciprocity, where the same photochemical effect with less illumination time is achieved if the intensity is increased. Here, the irradiation is increased to 9 milliwatts per centimeter squared, and the irradiation time is reduced to 10 minutes. The results are almost similar to the standard protocol with the increase in stability as well as in the vision. The effects and safety of CXL. The epithelium gets replaced in 3 to 4 days. Limbal stem cells are not damaged. Subepithelial nerve plexus starts to regenerate after 7 days. Immediately after CXL, there will be an apoptosis of keratocytes in the anterior stroma, but within few weeks, the new keratocytes migrate from the periphery. Collagen compaction and hyperdense ECM, what is expected of ECM of the extracellular matrix happens later, and there is no evidence of endothelial damage if the CXL is performed properly. What are the complications expected? Corneal haze is seen in 100% of the patients. It's usually temporary and resolves spontaneously. In 10% patients, it remains permanent. Stromal edema is a temporary complication seen in 70% of patients. Some patients develop corneal scar. Sterile infiltrations can occur in some patients because of reaction to the BCL antigens. And in infectious keratitis is also seen in cases of CXL. We have seen patients with bacterial acanthamoeba as well as herpetic infections post CXL, and diffuse lamellar keratitis is also seen in patients with post LASIK. So recently there are a lot of trials and studies going in CXL. These are some of the trials going on. In pulsed CXL, you use UVA light pulse on and off. In this trial, they say that because of the pulsed delivery of UVA, there is better oxygen diffusion. Better oxygen diffusion helps in better photochemical reaction and better formation of covalent bonds. And there are a lot of epithelium on protocols ongoing with chemical enhancers and iontophoresis assisted CXL, where a ring electrolyte filled with ionized riboflavin is used. And for CXL in thin corneas, you have customized pachy-guided epithelial removal, UV barrier-free soft contact lenses, lenticule assisted CXL. And in sub-400 protocol, you use low intensity UVA light, but you vary the irradiation time based on the stromal thickness. These studies are all in experimental level. And then we do have a customized CXL where you do a topography guided CXL, wherein the irradiation is increased in the central diseased part, where it is given in around 10 joules. Whereas when you go to the periphery, the intensity is reduced to 5.4 joules. And we do have a lot of experiments going on, CXL plus. This is mainly indicated in patients with mild to moderate KC with potential for visual improvement, along with that with sufficient stromal thickness. Simultaneous approach is better than sequential approach. So coming to the next topic, contact lenses in keratoconus. So the contact lens options available in keratoconus are depends on the severity of the keratoconus. In mild keratoconus, soft contact lens and RGP corneal lenses are used. In moderate keratoconus, RGP corneal lenses and Roscoe lenses are used. Advanced keratoconus, Roscoe lenses, scleral lenses are used. Severe keratoconus, the only option is scleral lenses. So what are the prerequisites of contact lens fitting? You need to do an accurate refraction. You should have a trial lenses for all these lenses, soft, rigid corneal lenses, scleral lenses. After you put the trial lenses and you assess the fit, you do the trial until you achieve optimal fit, and finally you order the lens and dispense the lens. So based on the material, you can use both soft and rigid gas permeable materials. In soft, you have only option of soft toric contact lenses. In rigid gas permeable contact lens, you have both corneal and scleral contact lenses. So soft toric contact lenses, you have two type of lenses. Conventional is the routine we use for the normal regular astigmatism patients. It is available up to 6 diopter of cylinder. The material is usually silicon hydrogel contact lenses. Whereas in specialized contact lenses, for keratoconus have a thicker center with thinner peripheral curves. They also have additional advantage of toric front surface and aspherical surfaces. It also comes in reverse geometry designs, and the periphery can be manipulated independent of the base curve. Full periphery as well as sector management is also possible. And these lenses usually have a laser mark at the inferior 6 o'clock position. So how do you assess the fit? What is the optimal fit for soft contact lenses? The lens should be centered and cover the cornea all around, and the movement should be very less of after a blink of around 0.2 to 0.4 mm, and there should be a very minimal gaze on minimum lag on all gazes, and the edge of the lens doesn't encroach the limbus at any point of time. And with push-up test, the percentage assessed should be 40% to 60%, and the vision should be stable after a blink. So in this video, you see that the lens is well centered and it is covering the cornea all around. And the movement is very minimal, and during after a blink, the lens doesn't cross the limbus. And in push-up test, the edge of the lens is we can move the edge of the lens freely over the inferior edge of the cornea. So what are the additional points you have to see in soft toric contact lenses? The fit should be stable and the axis should be aligned, and the lens should rotate back after a blink. The inferior laser mark should be always at the 6 o'clock. When if you push the lens again should come to a point of rest at the same position with the inferior laser mark at 6 o'clock. So coming to the rigid gas permeable corneal contact lenses, there are three types of lenses. You have the divided based on the diameter. Corneal lenses have a diameter ranging from 8 to 12.5 mm. Corneoscleral have a diameter ranging from 12.5 to 515 mm, and scleral lenses have diameter ranging from 15 to 25 mm. So there are two types of RGP corneal contact lenses, conventional and rose-K. Conventional lenses are spherical and aspheric designs are available for early KC patients, and in advanced KC you have multi-curve posterior surface designs. Rose-K lenses are specialized lenses designed for keratoconus. These lenses have a small optic zoned diameter with 5 to 6 spherical curves on the back surface joined by gentle transitions. They have additional advantage of customization of edge and toricity of the edges, and also they have one more advantage of asymmetric corneal technology, wherein the most of the cones are located inferiorly, and that inferior edge of the lens tend to lift up. While employing ACT, the lens inferior edge can be made more flatter. So and it has an advantage of better vision and comfort than RGP. So what are the fitting philosophies for RGP? You have apical bearing, wherein the lens rests on the apex of the cornea, The weight of the lens rests on the apex of the cornea, whereas in apical clearance, the lens weight rests on the paracentral cornea. The ideal fit that we need to achieve in keratoconus is the 3-point touch, where you have a central light touch and a mid-peripheral touch. The weight of the lens is shared in the center as well as in the mid-periphery. And what is the optimal fit? The first one is the dynamic fit, wherein you assess the relationship of the lens with the cornea after a blink. The lens is located usually in the interpalpebral region or under the lid. It stays within the limbus during gazes, and the movement is smooth, and the lens centers well after a blink, and it is stable. Then the static fit is you assess the lens fit with fluorescein, and you ask the patient to blink, and you assess the fluorescein, how it pulls. In the center, there will be a thin film with a feather touch in the center. Mid-periphery, the lens rests on the cornea, and there will be no pooling of fluorescein. And in the in the edge, there will be a ring of fluorescein of around 0.2 mm diameter. Coming to the scleral contact lenses, they actually vault over the cornea, limbus, and land on the conjunctiva overlying the sclera. The lens is filled with saline before insertion. It prevents saline prevents corneal desiccation as well as, and it also optically neutralizes the aberrations from the irregular corneal surface. There are 3 parts in the scleral contact lenses. You have an optic zone in the center, which is around 9 to 10 mm diameter, and it contains the refractive power as well as the base cover. And then the limbal transition zone comes. This walls over the limbus. It forms the transition between the optical zone and the haptic zone. And finally, the landing zone, which lands on the sclera and conjunctiva. This edge also has customizing choices of either a spherical edge or a toric edge. So what are the fitting principle of scleral contact lenses? You have to assess the vault and then assess the scleral landing, and then you assess the centration and movement of the lens with blink. So how do you assess the vault? Vault is the distance between the posterior lens surface and the anterior corneal surface. It is usually assessed in white light. You compare the vault with that of the lens or the cornea, and the central vault is ideal is 100 to 300 micron, and the mid-peripheral vault usually tapers from the center, but however there should not be any touch, and the ideal mid-peripheral vault and peripheral vault should be around 100 microns. This green colored fluorescent stained tear film is the vault. So this video shows a scleral contact lens trial lens over the eye. It's a case of post-hydrops case with a scar. You can see the compression suture marks. So this edge with gazes, superior, inferior, nasal, temporal gazes, there is not much of movement. The lens is well centered. Then you put a slit of white light to see the vault. So here you see the outermost layer is the lens. Then you see the green colored fluorescent, which is the vault, and then the inner same transparent layer is the cornea. So how do you assess the scleral landing? OCT helps in assessing the edge of the lens as well as the vault. The optimal scleral landing should be the lens should align over the cornea, limbus, and sclera. And in cases of tight edge, you can see blanching, compression, and impingement. When the edge is looser, you see air bubble coming through the periphery of the lens to center. So what are the important points before you prescribe contact lens? You should always stress on the compliance of hand washing before insertion and removal of contact lens. And contact lens care and maintenance, rub and rinse regimen should be followed every time. Whenever patient visits the contact lens, you ask the patient to wash remove and insert the lenses, and lenses should be stored overnight in a multi-purpose disinfecting solution. And contact lens case care also should be educated. The contact lens case also has to be changed once in a month, and strict adherence to replacement schedule of the contact lens and contact lens case is also a must. So when do you say a contact lens fit is successful? When you reduce total number of trial lenses and visits to the clinic, when the vision and comfort of the CL trial and dispensing is good. Instructions manual should always be given to the patient about the lens care and handling. And aftercare visits is a must for all patients, and always the wearing hours should be educated to the patients, and you have to make sure that the patient has a pair of spectacles to use whenever beyond the wearing hours of contact lenses. So another one important aspect in the management of keratoconus is the maintaining ocular surface health. Most of the keratoconus patients have associated allergy. The allergy can be treated with topical antihistamines, mast cell stabilizers, steroids, or immunomodulators based on the degree of the allergy and severity of allergy. Optimizing the ocular surface before any procedure is a must in cases of keratoconus, before you use contact lenses, before you advise surgery, or before CXL. So to conclude, once you diagnose a case of keratoconus, you look for progression. If there is progression, you proceed with CXL. Or if there is no progression, but even then if they have risk factors like young age, allergy, poor compliance, then you proceed with CXL. If there are no risk factors and then if you have done CXL, then the next point to see is you look for visual rehabilitation. So CXL, there is basically you look at thickness. If the thickness is more than 400, you go for isotonic, and if it's less than 400, you go for hypotonic. And in cases of thin corneas, corneal scar, acute hydrops, you don't do CXL. And for visual rehabilitation, it depends on the severity of the keratoconus. In cases of mild KC, you go for spectacles and soft toric contact lenses. Moderate to severe KC, you can use contact lenses based on the severity. You can for moderate RGP and RGP lenses and Rosquet lenses are used. When in advanced cases, you go for scleral contact lenses. And when in cases of CL intolerant patients, surgery is the only option. And in advanced case, the only CL option is scleral lenses. And if they are intolerant and if their occupation doesn't go in favor of contact lenses, the final option is final and only option becomes keratoplasty. Thank you.
Thank you, Dr. Devi. I'm sure it's a very important topic, the decision-making algorithm that you showed on when to do CXL and when to give contact lens for a patient is quite insightful. Revati madam and Radhika madam, any comments or points that you would like to add on this aspect?
Yes, Dr.
Yeah, ma'am, please go ahead.
No, you go ahead.
Yeah. So actually, two very nice presentations. I hope a lot of postgraduates are listening to it because what these two speakers spoke really gives in a nutshell as to what they need to know both for their exam and for their starting practice. I don't think in any textbook it is encapsulated in this format. So a couple of quick points. First, regarding Christy's talk. Apart from all the parameters that she mentioned, when a patient comes with keratoconus, we may be able to apply most of these. But when a patient comes for a general eye examination or even to the LASIK clinic sometimes, I always tell my patients and my postgraduates the diagnosis of keratoconus starts, much before the MAPS. So apart from the scissoring reflex and the jumping myopia and everything, so when the myopia changes also, we can try and correlate it with the axial length or even the tessellation of the fundus.
Any myopia which is over 5 or 6 diopters, which is not correlating with the axial length or the tessellation, instills a doubt in me that, this patient may be having keratoconus. Always the keratoconus need not be in the younger age group. Sometimes we miss keratoconus or its progression in the older age group. This is far and few in between, but even menopausal women and people on hormone replacement therapy also have the same hormonal influence that we talk about in pregnancy, etc. So that is a little lesser known and a missed fact. So there also we need to look for keratoconus progression. Here the paradoxic feature is that one of the parameters, like Dr. Christie pointed out, is thinning. But in menopausal patient and HRT patients, the cornea actually thickens. The logic is then why do they progress in terms of the keratoconus indices? Because the thickening of the cornea is because of hydration, and the glycosylglycans actually pull fluid. So it is not a healthy thickening. It's like watery thickening. So the cornea actually becomes more pliable despite being thick. The point that I'm trying to make is there if we use the pachymetry alone as a factor, we may think that the keratoconus is stable. And by the same token, in the normal population also, asymmetric bow tie, symmetric bow tie, these can be seen. So that alone is not a criteria. Like she rightly pointed out, the posterior elevation should be a guideline. And I don't know how many people have noticed this. It's not a sign or anything, but many young keratoconic patients also have a single cortical spoke cataract. So that is one feature. I'm not saying it's diagnostic, but if you see that, you can add it to your list of, diagnosing points. So these are some features which I thought that I should mention. And in keratoconus, we are all constantly looking at central cones. So there may be superior cones. There may be inferior pellucid-like keratoconus. So we must keep these rare variables also in mind. Regarding the question on cross-linking, so basically I decide based on the age of the patient. Younger, I would cross-link. Risk factor, I would cross-link, like, eye allergy, eye rubbing, patient who's likely to get pregnant or undergoing hormonal changes because of PCOD treatment. So these all we know are higher risk factors for the cross-linking. If it's an older patient who's willing for follow-up and has got adequate pachymetry, then I'll probably, wait and watch a little longer. And by the same token, she made a list of points, Dr. Devi, about the indications for cross-linking. So this risk factors for progression and waiting and watching does not apply for post-LASIK ectasia, because by definition in post-LASIK ectasia, the progression has already happened. So there, I think we have to make use of the warning window and go ahead with the cross-linking rather than wait for the progression parameters to happen. Also, it is difficult to apply any of these parameters for progression in post-LASIK ectasia, because there the ball game is totally different. Bellin-Ambrosio does not hold good. Your cornea is already flattened. You can't define progression, and the risk has already happened. So there, I think cross-linking should be done as soon as the diagnosis is made. Revati ma'am, you were going to say something.
I totally agree with all the points you made. Actually, nothing much more to add. You are right. And as the very important point, don't miss out the keratoconus progression in little older patients. That is now we see. And one more point I would like to ask the Dr. Radhika as well as others' experience. Do you see, like, because now we know the myopia is more due to the small screen exposure, phone exposure, online classes, all these things. I have a gut feeling that even in keratoconus also, we see more and more young children with a sudden progression and all due to this too much use of phone and this small screen monitors. So far, I have not come across any study categorically connecting both, but we do see that. So
I think that is an excellent point what you said, ma'am. That's an excellent point. It's a theory that I've had in my mind also. I think sooner or later we should do a study. So let's work it in a reverse manner. So we always want to do the corneal tomography and topography in an undilated state. Why do you want to do that? Because we know that the action of the ciliary body and the sphincter of the pupil, etc., have an effect on the peripheral cornea and on the pull on the collagen fibers, right? So that's why we want to do it in an undilated state. So same logic should apply here also. When there is a constant near focus and the ciliary body goes for a spasm and there is constant action of those muscles, it should have, by the same token, some effect on the cornea also. So these are all interlinked structures. So if the propensity is there, a normal patient, it won't hurt much. But everybody who rubs their eyes does not get keratoconus. You have to have a double hit, right? You have to have a genetic predisposition also. in a predisposed individual or a child, I also have always felt that this kind of eye strain or screen time related factor and accommodative spasm can have a role. So I think we can prove or disprove this easily by doing a kind of a case control prospective study. Excellent point, ma'am.
Thank you. Thank you for those wonderful points, madam. I think a lot of
And by the
learning for
same
us.
token, sorry, Dr. Divya, by the same token, I think this has been published that keratoconus patients benefit a lot with vision therapy, orthoptics and vision therapy.
One small question to the chairpersons, madam. Do you? I want to know about the riboflavin with the dextran and HPMC, madam. Any how to choose or anything? Is there any points regarding choosing riboflavin with dextran or HPMC? It's yes.
You're asking me?
Yes, madam. Yourself and Dr. Revati, madam.
Ma'am, you want to answer that?
So, as Mangala knows, like, some of our centers are using only HPMC.
Yes, madam. Yes,
Some of
madam.
them both we use, mainly
Yes.
for hypotonic, we use HPMC.
Yes, madam.
But only thing, like, we also from our Coimbatore protocol, even whatever we use HPMC or Dextran, we first initially hydrate the cornea a little bit with distilled water for initial few minutes and then start. Even in between also we used to apply a drop of distilled water to make the stroma more hydrated. But I don't know exactly how it works. I mean, whether it works or not. But that's what we use to reduce that the drying of the desiccation of the stroma. But I would like to know about Radhika's preference, what they do in this.
True, ma'am. We've all resorted to HPMC now, but I've always had this thought in my mind that whatever agent you use to swell the cornea a little bit, it may make it safe for the cross-linking in two ways. One is that excessive flattening which you see post-operatively may not happen. Endothelial protection is also more. But again, every coin has got two sides. So I've always thought that when we cross-link a cornea of adequate thickness because the patient is young or has a risk factor, then the swelling makes the cross-linking too superficial, because when the cornea deswells, then if you could have cross-linked X amount of cornea, you have cross-linked only X by 2 amount of cornea because you have swollen the cornea unnecessarily before that. So there is a trade-off. On one hand, the flattening effect and the endothelial protection is there, especially in borderline corneas. But in normal cornea, I still feel that you should not use either. You should use normal riboflavin. But then, like you rightly said, because of availability and because of clinical safety, we've all resorted to HPMC now.
Yeah.
Now, new drops are being available. I had a discussion with Professor Hafizi, and Dr. Mangla was also there in the recently concluded Keracon. They are bringing about drops. It's still in the trial with them, which is a kind of a riboflavin drop where you can achieve epi off results by epi on. At least that's what they are touting, because it doesn't require epithelial debridement or iontophoresis. I don't know how they achieve it, but the drop has a dual action, increasing the permissiveness of the corneal epithelium as well as the, bringing the saturation in the corneal stroma. That will be interesting to see, how that drop works.
And in case of when we are talking about collagen cross-linking, we should not forget, of late, like we started seeing corneal thinning, gradual corneal thinning and sterile thinning, melting, and sometimes even perforation. Even 7-8 years later, the C3R procedure. So that also we have to keep in mind when we go for C3R aggressively in very thin corneas.
Correct,
this in mind.
Correct, ma'am. Definitely, again, perfect pearl, because again, I feel why it happens is that when you do excess cross-linking or in a vulnerable cornea, you kill off the keratocytes. At that point, it doesn't matter because the collagen is already there and it gets cross-linked. Collagen turnover takes about 8 years or 10 years. So when the collagen turns over, where will the new collagen come from? It will come from keratocytes. So if you've killed off a lot of keratocytes, the problem doesn't happen instantaneously because they get by with the existing collagen. But when the collagen turnover time comes, at that time, the killed keratocytes are not able to, the alive keratocytes are not able to produce the turnover collagen. And that is when the, punched crater appearance and the melt start happening. So I think, this needs to be publicized or spoken about a little bit before people do aggressive treatment with CXL.
Yes.
Thank you, madam. Thank you for those beautiful points. We will now move on to our next speaker, Dr. Mangla, who will be talking to us on surgical management and rehabilitation in keratoconus.
Good evening, everyone. I'll be talking about surgical management and rehabilitation of keratoconus. I won't be going too deep into all the surgical part, but just giving you an idea in which patients which surgery has to be planned. So this algorithm already Devi had shown like how to proceed with the patient with keratoconus. So when the spectacles, when the CXL doesn't work, spectacles doesn't work, contact lens doesn't work, then we have to go for the surgical management. So all the clinicians should be asking like is the disease is progressive or stable, and whether the goal is for stability of the disease as such or the visual rehabilitation of the patient. And one more thing is the cornea is clear and thick enough or it is thin, and whether the patient is tolerant to contact lens. So and sorry. Yeah. So we have to categorize these surgical procedures into the procedures which will halt the progression, reshape the cornea for better vision, and then that replace the damaged tissue. So now, previously we had only few surgical options. Now we have little minimally invasive treatments like cross-linking, CARES, Bowman's membrane transplant, etc. So these will help us to go to prevent the more invasive transplants. So coming to the reshaping of the cornea, we have intrastromal corneal ring segments, we have corneal allogenic intrastromal ring segments, and corneal tissue addition keratoplasty, where we don't do a full corneal replacement, but we just do some additional procedures. So this corneal ring segments, ideal candidates will be mild to moderate keratoconus, central or paracentral cone, clear cornea, but contact lens intolerance. So really what we have to expect from this is they will improve the corneal symmetry, not a perfect vision like 6x6 very clear, but it can improve the corneal symmetry and can reduce the cylinder. We can always counsel the patient, and also the patient can still need a contact lens or a glasses, and we can combine with cross-linking with ICRS. So this is these rings will be there. Two tiny rings will be there in crescent shaped with PMMA, and they'll be inserted into the cornea by a tunnel. There are 5 models available: Ferrara rings, Kera rings, intrastromal rings, that is called Intax and Intax SK, and Mayo ring and cornea ring. So the Intax will be looking like this: 2 semicircular crescent shaped rings, and it will be tunnel will be made in the cornea, and then it will be inserted. So these patients, the corneal thickness should be more than 450 micrometers, and the cornea should be very clear. It can be done by a automated manual dissection or as well as femtosecond laser. So this is a picture how the Intacs are placed in the cornea, and here the effect is that intracorneal ring segments will flatten the steep part of the cone and reduce the visual distortions. And the basic principle is the hammock effect, so that the steepening is reduced and it causes flattening of the central cornea. So the complications will be like overcorrection, undercorrection, migration of the rings, extrusion, new vessel formation, and glare and halos. So overcoming these problems, now the corneal allogenic intrastromal ring segments is gaining popularity because of its biocompatible nature. So here the biocompatibility, because the donor corneal tissue is an allograft instead of the synthetic materials. So this also they have the same principle of flattening the central cornea. Here also the procedure is similar, creating tunnels in the cornea with a femtosecond laser or by manual, and the rings are placed in the steep axis. The goal is to flatten the steep cornea, improve the vision with glasses. Here also we are not going to aim for a complete clear vision, but the vision can improve with glasses and reduce the dependence on specialized contact lenses, and it can be complemented with C3R for halting disease progression. So this is the allogenic corneal tissue which is cut like rings, and tunnels are made in the cornea and they are inserted. So coming to the visual rehabilitation, once the disease is stabilized like with contact corneal collagen cross-linking, now Corneal strengthening procedures can be done. Now, visual rehabilitation. Visual rehabilitation can be done with topographic guided PRK and phakic intraocular lenses. So, topo-guided PRK, here an excimer laser is used to regularize the corneal surface, like how we do in any refractive procedure, along with a collagen cross-linking. And phakic intraocular lenses can be opted for a long-standing, stable keratoconus and no refractive instability. We can opt for a phakic intraocular lenses. So, for PRK with contact lenses, we have to use Athens protocol. So, here which patients we can consider are a mild keratoconus, significant irregular astigmatism, but they have to have an adequate pachymetry. Here, PRK works to reduce the higher order aberrations and improves functional vision. Here also, we are not going to aim for a 6/6 clear vision, and you should not do PRK alone in keratoconus, always pair with collagen cross-linking. So next is the phakic IOLs. The indications will be contact lens intolerant patients with clear cornea, stable refraction, and along with the deep anterior chamber are good candidates for phakic IOLs. Contraindications will be like advanced KC, stromal scarring when very high irregular astigmatism. Both anterior chamber and posterior chamber IOLs are available, but posterior chamber phakic IOLs are commonly used. Like this is one of the video of the phakic IOLs. The toric marking should be made, and otherwise no, it's the procedure the same as any normal in phakic intraocular lens. The lens is injected and the toric the lens is placed according to the toric marking. The procedure is same as any other phakic intraocular lens. So the disadvantages will be the IOLs can correct only the spherical and cylindrical error, but not with so much of aberrations. It's known that the keratoconus eyes have significant aberrations that affect the visual quality, but those will not be corrected in the IOLs. Complication, as any of the phakic IOLs, the pigment dispersions, endothelial cell loss, cataract, glaucoma can happen. So coming to the replacing tissue, then comes the keratoplasty. Here in our way, sometimes collagen cross-linking is not working, your contact lens is not fitting, you cannot, the disease is not stable, it is progressing, then we have to go for any of these surgical procedure like deep anterior lamellar keratoplasty, penetrating keratoplasty, or Bowman layer transplantation. So when to plan a DALC? It is when an advanced KC, central anterior stromal scarring, failed all these ring segment scares and contact lens intolerance. DALC can be preferred over PK because of no endothelial resection, long graft survival, and ideal for young patients. But technically, DALC is little demanding, but excellent results will come in experienced hands. A small video of DALC procedure. The ectatic part is marked. Then with the trocar, a big bubble is achieved. Type 1 bubble is achieved. And the brave slash is the side port is made and the anterior stroma is debulked. And the brave slash is done. And the remaining stroma is dissected. And the donor button is prepared and sutured. So when we go for penetrating keratoplasty, it is reserved for failed DALC and endothelial involvement and severe hydropsychia, like very dense scar involving the DM also. So here we have to counsel the patient. That is very important for lifelong graft care, and rejection risk also to be explained, and post-op astigmatism management and suture-related management also to be explained to the patient. And this is a PKP video, it's not playing anyway. And now in the new armamentarium, we have Bowman layer transplantation. It is one of the sensitive and specific indicator of keratoconus is the fragmentation of Bowman's layer. So here we can prepare an isolated Bowman's layer inlay for the eyes with advanced keratoconus, and a tunnel kind of a thing is made, and this Bowman's layer is manually dissected at the mid, and it is delivered into the mid-stromal pocket. This is also intended to restore the corneal anatomy, stabilize the corneal structure, flatten the central surface, and arrest the progression. So the primary visual benefits will be to enable for more comfortable contact lens wear by flattening the cornea, and also to continue contact lens wear in the future by halting the disease progression. This is one of the sequelae of keratoconus. Unattended keratoconus is acute corneal hydrops. Here we can do a first line of conservative therapy with the medications, but if you have such a large acute hydrops, we can go for a compression sutures. This will help us for a faster resolution and less scarring. So the clinical algorithm will be, if it is a progressive keratoconus, we have to go for a collagen cross-linking. Poor vision but clear cornea, we can plan for intracorneal ring segments or cares and contact lenses. And irregular astigmatism with clear cornea with good thickness, we can plan for a PRK with collagen cross-linking. Advanced with clear endothelium, we can plan DALK. It's a full thickness scar and very, very advanced keratoconus, we can go for a PK. So take-home messages will be early collagen cross-linking will prevent us for a lot of transplantation. Always we can combine procedures like collagen cross-linking with PRK, collagen cross-linking with contact lenses, collagen cross-linking with ring segments and all. And DALK will be the surgery of choice in keratoconus. And for all these patients, proper counseling will lead to a complete satisfaction of the patient. Thank you.
Thank you, madam. I just have a question to the panel. So what is the cutoff for DALK surgery, madam? And when would you opt doing a DALK surgery? I know amongst all the Arvind centers, I think Arvind Coimbatore does the highest number of DALK surgeries. So what is the criteria and when would you prefer doing a DALK over, even a CXL or just contact lens management?
Are you asking me?
Yes, madam. Yes,
No,
yes.
for me, it's very simple. If the patient is able to wear, it's not only able to wear, whether their profession or age and other things can allow contact lens use, and the corneal thickness is also relatively better, we can go for CXL and contact lens. But in our scenario, many times, either they are very small children, they are not able to, even they come in advanced stage or almost like moderate keratoconus. They won't even, till that time, they would not have even own glasses. So we don't know how much they will be able to handle contact lenses and all. And in such a situation, when the vision is not improving comfortably with glasses, then my preference will be to go for a DALK, which can give better vision also. And also, like, you kind of stopping the progression at least for many years. But at the same time, we have to, in children, sometimes even if they improve only up to 618, sometimes I go for C3R because they generally well tolerate. Even the suboptimal vision, they tolerate better. So if otherwise the criteria is okay, I'll go for a C3R, and later maybe they can go for a contact lens. They can manage lifelong if possible with that. But if it is not possible, then I'll go for DALK. So where you can't, the CXL and DALK, they are not, their aim is not the same. DALK is for visual rehabilitation. That's what we should keep in mind. When CXL alone or CXL with CXL, we can't improve the vision either with glass or if they are not suitable for contact lens, then better you switch over, go for DALK. That's the criteria. And Dr. Radhika can share her views.
Yeah, so yes, most of your points I agree, ma'am, but I have a slightly, different viewpoint in one area. I strongly feel that any transplant in the body should be done only when nothing else works. So going by that premise, I find the term contact lens intolerance being used loosely. So when you assess the patient and when you assess the keratoconus and as a clinician and as the contact lens specialist, you have done your best. Very few patients actually come under the category of contact lens intolerance. It's quite often because of a fear or lack of trial, or they don't. I tell the patients that don't decide and tell me in 4 days' time. In 4 months, you come back, then I will advise transplant for you. So very few come into the category that eye-wise or mentality-wise, they're not able to use contact lenses. Even if a DALK has to be done, I always advise the patient to prognosticate the vision with a PROS contact lens, because quite often in my practice, I've seen, especially the children, like you rightly said, they will come with counting finger vision in the eye with keratoconus. You'll think they're amblyopic. And like magic, the PROS contact lens will improve it to 6/9 or so. Whether they want to use it later or don't want to use it is besides the point. At least as a surgeon, you have the idea in your mind how to prognosticate it for the patient. So I firmly believe that every patient should undergo at least a trial of scleral contact lens, if possible, usage for 4 months before going to a DAL. But there is the converse also. If the patient can be, I have a lot of faithful contact lens users in my keratoconus practice. But then PROS is only going to give the vision in terms of correction of the ectasia, a little bit of scarring. It's not going to give any support to the cornea. So these corneas sometimes are not cross-linkable. You have 300, 250 micron scary corneas, which are improving to 6/9 with PROS. Then what do? You continue PROS because patient is tolerating it with good vision, or you do DALC worrying that they will go for a high drops. So that fear is also there. So if the PROS contact lens patient cannot be cross-linked, then very close observation is required so that they don't go into high drops. And if we do a surgery, just for the starting surgeons, any surgery you do DALC or PKP, make 100% sure that you're encompassing the base of the cone, because we tend to get carried away by the logistics and the fancy of the procedure seen in the video. We don't get into the basic concept that the cone has to be excised, because you can get keratoconus post DALC or post PKP just because the base of the cone has not been encompassed. And regarding the compression sutures that was spoken about right now, again, one small word of caution, which I've learned by experience, that in central large tears, compression sutures work beautifully. So immediately you will see the cornea deturgescing on the table itself. It works by the principle that you're bringing the layers of the cornea together, the lips of the break together, and the sutures also work like, venting incisions. But a small word of caution that sometimes for these high drops, 1,500 micron cornea, which is swollen, the apex may still be very thin. You may have a lot of edema, which is clouding the thinness at the apex. So it is well worth doing an ASOCT to see which is the thinnest point of that bloated cornea, so that you avoid that while taking the compression suture. Otherwise, paradoxically, you may end up perforating the cornea also. So these are my, few practical tips on surgery for keratoconus.
Yeah, it's true. Like routinely we do ASOCT if at all we are going to take for a compression
sutures.
That matter, even DM detachment post surgery. Before intervening, we always do this thing to understand. Yes, I agree.
Have some people who have very boggy corneas, but the apex is actually very thin. In those cases, I even resorted to doing it in a hexagonal fashion, the compression sutures, rather than taking the bites at the center.
I think Madam Revati Madam has one experience of doing that for compression sutures, like Madam said, like hexagonal. Madam was you doing that lamellar, but we didn't go for Madam.
Yes. Then they are, as you said, very thin. I am very sad to go to the near paracentral area. I go to the periphery and compress.
Yes, ma'am. Exactly what I was saying.
Radhika Madam, one more question regarding cross-linking and the PRK, topo-guided PRK. What's your thought on it, and when do you actually do it for patients, or do you have any criteria?
So Dr. Divya, it's a limited spectrum of indication that you want to, combine the two. So basically, you want to regularize the cornea to an extent that the patient has got reasonable spectacle corrected vision and better fit of contact lens, but you don't want to weaken the cornea further. So when a patient has got 400 plus pachymetry and not too much of irregular astigmatism, then we can go for this procedure. The aim is not it's not refractive, it's not to reduce the glass power or give perfect vision. The aim is that their spectacle corrected vision can be improved a little bit without compromising on the the weakness of or the strength of the cornea.
Thank you, madam. Also, one point, if I may add, madam, I think for phakic IOLs, it's better to avoid it in patients who have used rigid contact lens for a long time.
Okay.
Right? Because I think the aberrations are corrected with a rigid contact lens to a certain extent. And when you end up doing phakic-IOLs in these patients, they might not see the vision
As
as
well.
clear as what they would see with the
Yeah.
contact lens.
Excellent point. In that same respect,
Exactly.
it is always better to assess the best spectacle corrected vision and find out if the patient is happy with that before actually resorting to phakic IOL, or the patient may still be willing to continue contact lenses, occasionally. The spectacle corrected vision is an indicator of whether the patient will be happy or not.
Thank you, ma'am.
As I think we are out of time, and I thank all the speakers for the wonderful talk we have made on keratoconus, and I also again thank our chairpersons who have given us extremely excellent points, practical tips to go ahead with the management of keratoconus. And thank you all for the audience also who are patiently listening for these talks and made this webinar so successful, and I thank one and all. Thank you.
Thanks, Dr. Mangala. I sincerely feel that all the 3 topics discussed now should go into a capsule for postgraduate education. Because it's like everything is given to them in a nutshell, what will happen in their exams and what is going to be asked later. I sincerely wish that the PGs and even fellows will make use of this webinar.
Yes, madam. Actually, we were planning for a general practitioners and fellows so that we didn't go into too much of detail.
Correct.
Yes,
but
madam,
the right amount of
it.
detail was there. So it was very nice. Thank you so much.
Thank you, madam. Thank you.
Madam.
Thank you. Thank you, Christy. Thank you, Divya. Thank you, madam. Thank you, Revati, madam. Thank you, Devi. Thank you. Thank you, Lokesh.
Thank you, madam.
Thank you, Dr. Radhika, for your time. Thank you. Thank you all.
Ma'am, it was indeed my pleasure, ma'am. I should thank you for having me.
Thank you, Christy and Divya, Devi, Mangala, all of you. Really,
thank you, madam.
All the talks are really good. Excellent.
Thank you, madam.
Thanks, Chandrasekhar sir, for being in the background always.
Yes, madam.
Arvind, whether it is webinars or in-person conferences, that warmth is always there. So that is an additional point.
Yes.
Thank you.
Thank you. Thank you, madam. Thank you.
Thank you. And good night, all of you.
Good night. Good night.